Hello and welcome to the paper presentation of the paper Who's Trusted for a Second Opinion, comparing collective advice from medical AI and physicians in biopsy decisions after mammography screening. My name is Henrik Detjen and I'm presenting this work on behalf of my co-authors Lars Densky, Niklas von Kalkreuth and Marvin Kopka. We are affiliated with Fraunhofer Mewes and Berlin Technical University. To better frame our research, we used the framework discussed in Kim et al. At CHI 2024, How Much Decision Power Should AI Have? They provide a patient-centered lens on the authority that AI has in the health-related decisions. So traditionally, here on the left side, the patient P directly interacts with his or her healthcare provider. So how does this change? In modern medicine, more and more patient and physician interfaces include highly capable AI features, for example, for diagnosing diseases or predicting treatment outcomes. And many people already put their health-related data into large language models, for example, to get a second opinion on their health status. And this brings a new medical entity into the patient's health-related decision-making and transforms our current understanding of patient involvement and shared decision-making. Constellations include, here on the left side, patient-led, or on the right side, an AI-led decision-making, where the healthcare provider here on the bottom side acts as a confirming instance. However, if there's no strict protocol, no strict decision protocol, and all parties involved consult and advise each other, then there is the question how the final decision is made. In our paper, we focus on a second opinion scenario where a patient gets two opinions or two advices from his or her healthcare provider and from an external AI. So here we have a patient in a breast cancer screening scenario with suspicious findings, and he or she needs to decide for a follow-up and gets advice from a second opinion app called MammoJourney and an advice from the healthcare provider for or against a follow-up biopsy. To better understand the collective decision-making scenario, we carried out two studies in a mixed message approach that combines qualitative interview data with quantitative survey data. And we had two research questions. The first one is, what is the influence of this medical advice giver, so human or AI, on the patient's trust, the attitudinal trust or behavioral trust in this collective situation? And the second question is, how does the second opinion, so the consonant or the dissonant advice, influences the patient's decision-making process? And we did interviews with 9 participants and an online survey with 339 participants. To better understand the collective decision-making space, we first started with better understanding breast cancer survivors' perspective on AI in breast cancer diagnostic with semi-structured interviews. We had 11 questions and 40 sub-questions, and we asked 9 participants, 9 females, around 42 years old, and we recruited them via local networks. For analysis, we used inductive reflexive thematic analysis, and we found 3 main themes: diagnosis with 4I principle, patient empowerment, and AI lack of empathy. The first topic was about diagnosis with 4I principle. So participants found AI to be a valuable tool for verification of diagnosis and error reduction, and for integrating new studies in the expanding treatment option space. And one citation here from one participant is, if I had the option to use AI during screening, I would definitely have taken it, not because I felt insecure. On the contrary, I was in good hands with my doctor, but I would have certainly used it as an additional source of information. The second theme is patient empowerment, and AI can enhance the independence, making decisions more informed, and provide access to treatment information. So AI can enable active health management, reduce doctor visits, and increase convenience. A citation here is, you have access to all the data, you can control it yourself, send it more easily, and also find out about the treatment process. The third and last theme is AI's lack of empathy. AI can lack human empathy and emotional awareness in medical decisions, so patients emphasize the impact of compassionate communication in stressful diagnostics. A citation here is, I would actually reject it. Because sure, AI can do a lot, but every person is so individual. What am I putting this woman through? What age is she? What does she still have ahead of her? I think you have to take so many things into account, and it's so individual that I wouldn't let make AI that decision. I would always trust people. After understanding the patient's situation better, we did an online survey in a 2x2 mixed design where we had a medical entity, which were human or AI, and within subject setting and in the medical advice, so for or against the follow-up biopsy after mammography screening between subjects. And we measured trust, attitude, and behavior towards this entity and the decision to do the follow-up or not. Overall, we had 339 participants. Of those were 12 non-binary and the rest were females. And their age was around 30, and we recruited them via Prolific. For analysis, we did a paired t-test to measure trust attitude or to test for differences in trust attitude and binominal logistic mixed effect models for trust behavior and binominal logistic regressions for the decisions. The procedure was as follows. Let me point this out. We constructed a realistic case vignette with the RepWig framework. Then participants got an advice from a human or an AI entity, and then they had to decide whether to follow up the mammography screening or not. And then they got a second opinion, and it was, if they had experienced the human opinion first, then it was the AI opinion, or the other way around. And then afterwards, they had to decide for the mammography screening again, and had to attribute their trust towards the entities. Our results show that participants had generally a significantly higher trust attitude towards the physicians than towards the AI. And they also complied more frequently with the human advice by physician, around 80%, than by the AI, which was around a third. And our results might be explained with the algorithm inversion bias. In the interviews, this was mentioned with the lack of empathy, for example. And future systems should address this aversion on emotional levels, such as using empathetic design, or on cognitive level, such as using educational materials or providing a simple risk communication. Regarding the biopsy decisions after receiving two advices, when the advice is consonant, so in the left and the right situation, participants usually go with the recommendation. In the case where both advise against, so on the left side, still some go for it. In the case where the advice is dissonant, so either human or AI advise against it, participants still significantly opt more often for the biopsy. And the human advice nearly leads to full adherence. And interestingly, even if the less trusted source recommends the biopsy, the AI, 2/3 adhere to this AI recommendation. So a possible explanation for this is that as soon as there's risk and insecurity in the room, people want to avoid it. And future technology design that is touching this collective decision-making space has to account for these insecurities by providing conflict resolution mechanisms. The key takeaways of our papers are, so first from the interviews, patients value AI as an additional entity to foster a 4I principle, and that empowers them in their health-related decisions, yet it lacks empathy. Second, from the online survey, we found that medical AI is less trusted than physicians, yet in the conflicting scenarios, both lead to increased adherence for follow-ups. And third, as design implications, medical AI design should address trust calibration, risk transparency, empathy, and conflict resolution. Thanks.